In our last video, we covered the real side effects of cholesterol medications. Now, let's address the claims that you've almost certainly encountered on social media from well-meaning friends or from internet searches that are keeping millions of people off medications that could save their lives. Each of these has been directly studied in large, rigorous clinical trials. Here is what the evidence shows. Myth number one, statins and low LDL cause dementia and memory loss. This is one of the most widespread and damaging myths in cardiovascular medicine. Let's address it head on. The concern originated largely from anecdotal reports and a 2012 FDA label update that added a warning about memory loss and confusion to statins based on spontaneous case reports, not clinical trial data. This label change was controversial among cardiologists and neurologists from the start. What do the actual trials show? The EBBINGHAUS trial, a dedicated cognitive sub-study of the major FOURIER outcomes trial, specifically tested whether evolocumab, which is a PCSK9 inhibitor that drives LDL to extremely low levels, often below 20 milligrams per deciliter, affected memory, executive function, or brain health. It was published in the New England Journal of Medicine in 2017. It enrolled over 1,200 patients and administered rigorous, validated cognitive assessments at multiple time points. The result? No adverse effects on memory, executive function, or any other cognitive domain, even at ultra-low LDL levels that would have been considered dangerous a decade ago. Multiple large meta-analyses of statin trials involving tens of thousands of patients have found no increase in dementia, Alzheimer's disease, or cognitive impairment with statin use. In fact, several observational studies have found lower rates of dementia in statin users, though this may reflect confounding rather than direct neuroprotective effect. The bottom line, the fear of dementia from statins or very low LDL is not supported by the evidence from rigorous clinical trials. Myth number two, low LDL causes cancer. This myth has periodically resurfaced since the 1990s when a few small early studies noted a statistical association between very low cholesterol and cancer incidence. That association turned out to be reverse causation, meaning undiagnosed cancer was causing the low cholesterol, not the other way around. What do large-scale studies show? A meta-analysis examining data from over 175,000 participants across multiple major statin trials found no link between intensive LDL lowering and cancer incidence or cancer mortality. This has been confirmed across multiple independent analyses. People with genetic variants that cause lifelong very low LDL, including PCSK9 loss of function variants and ApoB mutations, do not have higher cancer rates. If low LDL caused cancer, we would expect to see this in people who have had very low LDL their entire lives, and we do not. The American Cancer Society, the American Heart Association, and the FDA have all reviewed the totality of evidence and concluded that there is no causal relationship between LDL lowering at any level achieved by currently available medications and cancer risk. Myth number three, very low LDL causes hemorrhagic or bleeding stroke. This concern has more biological plausibility than the cancer myth. LDL does play a role in maintaining cell membrane integrity, and very early observational data in Japanese populations suggested a possible link between low cholesterol and brain bleeds. Now, this is worth taking seriously. However, the totality of clinical trial evidence does not support this concern at the LDL levels achieved with currently available therapies. The FOURIER trial, a major randomized trial of evolocumab in over patients with established cardiovascular disease, achieving median LDL levels of 30 milligrams per deciliter, showed no consistent increase in hemorrhagic stroke. In fact, total stroke rates, including hemorrhagic stroke, were lower in the treatment group than in the placebo. The ODYSSEY Outcomes trial of alirocumab similarly showed no increase in hemorrhagic stroke and a significant reduction in total stroke. Across the combined data from PCSK9 inhibitor trials, which have driven LDL to lower levels than ever before tested in large randomized populations, there is no signal of increased brain bleed. For context, the benefit of LDL lowering on ischemic stroke, which is the far more common type caused by artery blockage, is substantial and consistent. A 1 millimole per liter, approximately 39 milligrams per deciliter reduction in LDL reduces stroke risk by about 21%. The hemorrhagic stroke concern, while not zero in theory, is not supported by the clinical evidence at therapeutic LDL levels. Myth number 4, very low LDL disrupts sex hormones, testosterone, estrogen, and adrenal function. Now, this myth has particular traction in certain wellness communities and is worth addressing carefully because it sounds physiologically plausible. Cholesterol is indeed the precursor to all steroid hormones: testosterone, estrogen, progesterone, cortisol, aldosterone. The concern is, if you lower LDL dramatically, do your hormone levels drop too? And the answer, based on clinical evidence, is no. And here is why. The cells that produce steroid hormones in the gonads and adrenal glands are not dependent on circulating LDL for their cholesterol supply. They synthesize their own cholesterol locally and also take up HDL cholesterol and other lipoprotein particles through different receptor pathways. They are exquisitely capable of maintaining local cholesterol production independent of how low your circulating LDL goes. Clinical trial data bears this out. In the FOURIER trial, patients with LDL levels driven below 20 milligrams per deciliter showed no change in testosterone, cortisol, or adrenal function compared to placebo. Multiple other large trials with very low achieved LDL levels have not found hormonal disruption. People with familial PCSK9 loss of function mutations who have had extremely low LDL their entire lives from birth have normal reproductive function, normal hormone levels, and normal adrenal function. Nature's experiment confirmed the clinical trial data. Myth number 5, statins cause cataracts. This concern arose from a 2012 observational study that found a statistical association between statin use and cataract diagnosis. However, observational associations are prone to confounding. Statin users visit doctors more frequently, they get more eye exams, and therefore they have more cataracts detected, not necessarily more cataracts formed. When randomized controlled trials which control for these biases have been examined, the picture is clear. The ODYSSEY Outcomes trial, which randomized over 18,000 patients to alirocumab or placebo with rigorous follow-up, found cataract rates were statistically identical between the intensive lipid-lowering group and the placebo group. Multiple other large statin trials have not found an increased rate of cataract. A 2016 meta-analysis in JAMA Ophthalmology examined the totality of clinical trial data and found no causal relationship between statin use and cataract formation. Now, nature's experiment, the most powerful evidence of all. Perhaps the most compelling evidence that very low LDL is safe comes not from clinical trials, but from human genetics. Certain people are born with genetic variants that dramatically reduce their LDL, specifically loss of function mutations in the PCSK9 gene and variants in the ApoB gene. These individuals have circulating LDL levels of 15 to 30 milligrams per deciliter their entire lives from birth. They are not on medication. They are just built differently. These people are not cognitively impaired. They do not have hormonal dysfunction. They do not have higher cancer rates. They do not have more cataracts. They do not have more hemorrhagic strokes. What they do have is dramatically lower rates of coronary heart disease. Studies show a 75 to 88% lower risk of heart disease over a lifetime compared to people with normal LDL levels. This is nature's randomized trial. It tells us that very low circulating LDL is not only safe, it is the state our biology is in many ways designed to function well in. The high LDL levels common in Western populations are the evolutionary mismatch, not the treatment. Now, the lower for longer principle. The 2026 ACC/AHA guidelines formally adopt what cardiologists now call the lower for longer principle. The cardiovascular system experiences cumulative exposure to LDL over a lifetime. Every year of elevated LDL is another year of plaque deposition, inflammation, and arterial injury. Conversely, every year of lower LDL is a year of reduced deposition and, over time, partial plaque stabilization. Mendelian randomization studies, which use genetic variants to estimate the lifelong effect of lower LDL, consistently show that the cardiovascular benefit of lower LDL achieved through a lifetime of genetic predisposition is 3 to 4 times greater than the benefit seen in a 5-year clinical trial with the same degree of LDL lowering. Time matters enormously. Starting earlier and staying on treatment longer multiplies the benefit. This is why the 2026 guidelines now recommend considering cholesterol treatment in adults as young as their 30s when LDL is elevated, not because a heart attack is imminent at 35, but because every decade of lowering LDL compounds into dramatically lower lifetime risk. So here is what the evidence tells us. The feared side effects of cholesterol medication, dementia, cancer, hormonal disruption, hemorrhagic stroke, cataracts, have been directly tested in rigorous randomized trials involving hundreds of thousands of patients, and the evidence does not support them as real risks of LDL lowering therapy at therapeutic levels. And the genetic evidence from people born with lifelong very low LDL tells us something profound. Very low LDL is not dangerous. It is, in many ways, protective. Don't let misinformation stop your progress. If you have concerns about your medications, bring them to your doctor. You deserve a real conversation based on real evidence, not fear based on social media. Achieving very low LDL cholesterol provides greater heart protection with a favorable safety profile. Clear communication and shared decision-making are the keys to your better long-term health.